Hello, dear student. I will today present a lecture on the electrolyte disorders related to neuromuscular and cognitive dysfunction. This lecture is mainly a revision of what's been taught during my course of electrolyte and acid base in semester 8. I will divide this lecture into probably two parts to make it more available for you over the internet. Uh, First, let us know that electrical potential exists across the membranes of virtually all cells of the body. In addition, some cells, such as nerve and muscle cells, are capable of generating rapidly changing electrochemical impulses at their membranes, and these impulses are used to transmit signals along the nerve or muscle membranes. And this is quite important for cell function, especially for the function of the nerves and the muscles, so as to conduct neurological impulses for sensation, for movement, and to run skeletal muscle activity and smooth muscle activity. So without this electrical potential activity across the cell membrane, this function would not be able to be exerted. This is dependent actually on the movement of sodium and potassium across the cell membrane in the nerve function and in the muscle function. And you find that having a high intracellular concentration of potassium and a high extracellular concentration of sodium creates some imbalance in the concentration between the intracellular and extracellular, and this imbalance is to some extent neutralized or balanced by the electrical disbalance that occur by movement of any of the electrolytes to either side of the cell membrane. But commonly, we usually following the movement of potassium from the high concentration inside the cell to the outside the cell, it creates a negativity inside the cell, and this is quite strong, nearly negative 94 millivolts. Some other cells can permeate sodium to inside, and this permeation of sodium into inside creates a net positive charge inside the cell while leaving a negative charge outside the cell, creating an electropositivity inside the cell of nearly positive 61. Upon this depends the function of some nerves and muscle cells, and some cardiac and smooth muscles as well. So some cells can alternate the permeability in their membranes between high potassium permeability and high sodium permeability according to some certain stimuli. And we've got the sodium potassium channel, like the sodium potassium ATPase pump. This is energy consuming that restores the balance back again between the extracellular sodium and intracellular potassium. Some other channels are called leak channels, can also have to admit the sodium inside and potassium outside, as I said in the previous slide. So many stimuli can produce diffusion of either sodium or potassium across the cell membrane, thus generating some disbalance between of them and generate some electrical impulses and electrical currents that can goes along the membrane. So this creates the typical action potential when some stimulus come, and this stimulus change the permeability of the membrane so as there is influx of sodium and efflux of potassium, so as to generate depolarization of the basement membrane and even reversal polarization. The calcium ion also play a very important role where there is a calcium pump in many of the cells in the body, and this calcium serves along with or instead of sodium in some cells. But this calcium pump usually are slow to act, so they are thousands times slower than the sodium channels, but it is very important to generate this electrical instability across the cell membrane. Some other gates or channels of calcium are called voltage gated, and these are even more slower, and they are very important for calcium for cardiac and smooth muscle cells. So increased permeability of the sodium channels when there is a deficit of calcium ions occurs. So when there is calcium ion, there is when there is deficit in calcium ion, there is more potential for sodium influx inside the cell and reversal of the membrane potential and generation of action potential even without other stimulus. So hypocalcemia is usually manifested by some irritability of the neuromuscular cells. Here is what happens in the cardiac action potential when there is different phases. The first phase is the phase of depolarization, with the sodium enters the cell, causing depolarization, and then repolarization occur by calcium influx inside the cell, and then phase 3 is potassium exiting the cell, and then there is resting membrane potential back again. So this happens in the cardiac cells, and some part of the cardiac cells of the myocytes are automatic in having this cycles even without stimulation by external stimulus. So they are rhythmic in generating this electrical problem. And calcium, sodium, and potassium, especially calcium, are very important in the myoneural end plate for generating an action potential that is transmitted from the nerve ending to the ganglia or to the muscles to generate another stage of electrical potential. So there will be then starting the muscle contraction depending on pumping calcium from the channels inside the cell to act on the actin and the myosin, causing sliding of them and changing the physicochemical characters, causing muscle contraction. So we have, especially in cases of chronic renal failure and in nephrology study, we have some causes of encephalopathy. And one important cause of encephalopathy and cognitive changes in these patients are fluid and electrolyte disturbance, especially hypercalcemia, hypermagnesemia, hypernatremia, hyponatremia, hyperosmolality, hypoosmolality. And all of these are important causes of encephalopathy in patients with renal disease. The electrolytes are very important also for generation of osmolality and the keeping of the volume, both of the ECF and of the intracellular volume. Now, just I remind you with the meaning of osmolality, we've got in our body some solutes dissolved in a solvent, and this solvent usually is water, H2O, and the body is subdivided into different compartments. Between the compartments there is a membrane, and sometimes this membrane is characterized by a semi-permeable characters which can easily pass water but wouldn't pass certain types of osmols or certain types of solutes that are dissolved in water. So as long as water can dissolve between the two types of solution, then there will be an equilibrium in osmolality between these two types. But if you hypothetically add some solute to one side of the membrane, then you would expect that water would move from the low concentration into the vessel of the high concentration, so here creating more volume in side B than in side A, and the volume in side A will decrease in order to keep an osmotic balance between the two sides, because water can shift. If water couldn't shift, then osmotic balance would not be created. Inside our cells and outside the cell, there is a membrane separating between them. This membrane is the cell membrane, which is a semi-permeable membrane. It is not easily permeable to most of the electrolytes, and you will find change in the concentration of something like sodium outside and sodium inside, potassium outside and potassium inside, calcium outside and calcium inside, and so on. Some are very high inside, like potassium, some are very high outside, like sodium, and with its anions, like chloride and bicarbonate. Here inside the cell, we find phosphate is high and amino acids are higher than outside. So this cell membrane is a facultative membrane that governs the diffusion of certain ions across the cell membrane in a very regulated manner. But water can, to a great extent, pass freely across the cell membrane. If you look, you find that sodium outside the cell as a cation. If you look at the other cations are the positively charged, like potassium, calcium, magnesium, or the neutral, like glucose or amino acids or fats. You will find that sodium is very, very much dominant in, in terms of concentration. Here, sodium is 142, while potassium is 4, calcium is 2 point something, magnesium is 1.2. This is chloride is an anion, so we shouldn't count it, because anion and the cation will balance each other together. But if you look at glucose, don't be fooled by the 90, because this is 90 milligram per deciliter. But if you take it in moles, it is nearly 5 millimole per liter. Amino acids are also very tiny if you take it in millimoles. So sodium is the only dominant cation outside the cell. And if you know that every cation should be accompanied by anion to balance its electricity, to make an electrical neutrality, then if you time sodium by 2, then you can count for the accompanying anion to it, and you will find it 284 or something like that, which constitutes the majority of the ECF osmolality. If you look inside the cell, you will find potassium is very dominant inside the cell, while the others are a lot less. Magnesium might contribute a bit, but not as much as potassium. So potassium is the main factor playing for osmolality inside the cell in the intracellular fluid, while sodium is a major factor playing for osmolality outside the cell in the ECF. And actually, you can determine the osmolality of the ECF if you take sodium, just sodium alone in consideration. You time it by 2, you get 280 something, while the total osmolality of the ECF measured by an osmometer is usually around 290. So it's not that far. So you can just take the sodium as an indicator and the main player of the ECF osmolality, and also to some degree you can consider potassium as the major player of the intracellular osmolality. Remember that concentration, which is a reflection of osmolality, or which is reflected as osmolality, is dependent on the amount of solutes divided by the volume, and the amount is in molar amount to get it in osmolality terms. And the volume is the volume in liter of the solvent here, which is water. So amount and volume will determine the concentration and will determine the osmolality in every part. But as long as water can move freely, so water will move from any low osmolality to any high osmolality until they produce a balance. And this movement, of course, will change the volume. So I can say that as long as we have our compartmentalization design in our body, we've got the cell compartment and the ECF compartment. The intracellular compartment constitutes nearly 40% of the body weight, while the extracellular fluid compartment constitutes around 20% of the total body weight. The extracellular fluid compartment is subcompartmentalized into interstitial fluid and the intravascular fluid, which is plasma. And the interstitial fluid is 15%, while the plasma is 5%. So the total body water or the total body fluid is nearly 60% of the body weight. And if we take sodium inside the cell, it's not significant. It's 10 millimole per liter, but outside the cell, it's very dominant as concentration. It's 140 millimole per liter, right? So the total body sodium, you can calculate it 10 times 28, which is the volume of the intracellular fluid, plus 140, the concentration in the ECF, times 14, which is the volume of the ECF. It gives you 2,240 millimole as the total body sodium content. But this total body sodium content is, as I said, distributed unequally between two different compartments. But if you intake sodium, like if you swallow sodium or ingest sodium or have sodium infusion in your body, this will go to the ECF, both the interstitium and the vascular compartments, but it wouldn't go easily to the cell because the cell membrane, as I said, is not permeable freely to sodium. Thus, ECF volume is dependent on the amount of sodium in the body. If you add more sodium, you get more volume in the ECF. How is that? Because if you add here sodium, you will create some concentration and the fluid will move from the cell to the ECF, and the individual will feel very thirsty and will drink water, so he will increase the volume of the ECF. While if he did not drink water, the volume of the cell will decrease. On the other hand, cell volume is dependent on the amount of potassium inside the cell divided by, the concentration of potassium inside the cell divided by the concentration of sodium outside the cell. So if the sodium outside the cell as a concentration, not amount, is decreased, then cell volume will increase. If it increased as concentration, cell volume will decrease. On the other hand, if the intracellular potassium concentration is increased, cell volume will increase. If the intracellular concentration of potassium decreased, then the cell volume will decrease. So you think of your body and your compartment, especially the ECF, as just some salt, and in the ECF it is usually sodium chloride salt and some water. It is easier to play with water rather than to play with salt because water can come from the cell, water can come from drinking water, which is very abundant around us, and we can drink a lot of water, while the change with salt or the play with salt is not that much. It occurs, but it's not that much common as playing with water. Now, let us consider decreasing concentration of sodium in the ECF. When I say word hyponatremia or hypernatremia or hypokalemia or hyperkalemia, by this emia, we talk about the concentration in the plasma or in the serum. And it reflects for most of the small ions, it reflects the concentration in the ECF, because these small electrolytes flow freely across the capillary wall. So there is no difference usually between the concentration of sodium, potassium, calcium, phosphorus, magnesium, glucose, amino acids between the capillary wall, between the interstitium and the plasma. So hyponatremia is plasma sodium below 135. It is frequent in hospitalized patients and less frequent, less common in ambulatory patients coming to the outpatient, but still present. And it may be a finding that lead to a diagnosis of specific disease states like heart failure, like liver cell failure, like undiagnosed Addison disease, hypopituitarism, hypothyroidism, etc. So when you diagnose or you identify hyponatremia, you've got to search of the causative problem. It can also indicate the use of excessive use of diuretics or the use of other drugs like cytotoxic drugs or immunosuppressive drugs. And in some cases, it can be a feature even of cancer, like oat cell carcinoma of the lung. So it is a serious problem when you find somebody with hyponatremia, whether it is not severe or severe, then you should uh, play your part in finding the diagnosis of the causative problem. The signs and symptoms of hyponatremia are usually the signs and symptoms of hypoosmolality, and it depends on changes in the brain. It is related to the severity of the case, severity of the hyponatremia, the rate of decline, and the age of the patient. The rate of decline, the quicker or the faster the decline, the more manifest hyponatremia, and the slower, the less manifest. And of course, the more severe, the more manifestation, the less severe, the less manifestation. And old age patients are more vulnerable to the manifestations of hyponatremia and hypoosmolality. This because brain requires time to accommodate for the decreasing serum sodium. So if the decrease is quick, the brain wouldn't have time to accommodate for that. If the decrease is slow, then the brain might be able to accommodate that until severe conditions develop. The brain disorder would manifest as muscle cramps, lethargy, disorientation, agitation, decreased level of consciousness, decreased deep tendon reflexes, pathological reflexes, and the development of cayenne stalk respiration, development of hypothermia, pseudobulbar palsy, convulsions, seizures, and coma. Some manifestations are also related to the affliction of the gastrointestinal tract, like anorexia, nausea, and the vomiting, may be because of the edema and swelling of the mucosa of the GIT or the problem with the chemoreceptor trigger zone. So this is the brain and how it accommodates and how it is vulnerable to the changes in serum sodium concentration and serum potassium. How would we approach a patient coming with hyponatremia? We measure plasma osmolality, and hyponatremia is that of true hyponatremia is that associated with hypoosmolality. But if osmolality is normal, we call it a pseudo hyponatremia. If it is high, we usually say it is an osmotic type of hyponatremia, which is not a true hyponatremia. When we know that the patient has got true hyponatremia, which is our interest here, we go and measure the ECF. So hyponatremia is diagnosed by lab. You go and analyze serum sodium concentration, you find it low, then you say it's hyponatremia. And to make sure that it is true hyponatremia, then you measure osmolality, you find hypoosmolar. And then the other part of the diagnosis is not dependent on lab, but dependent on clinical examination. You go and examine the ECF volume by inspection, palpation, percussion, auscultation, and sometimes radiology. And you classify hyponatremia into those with decreased extracellular fluid volume, those with normal, and those with expanded extracellular fluid volume. Those with expanded extracellular fluid volume are possibly due to renal failure, nephrotic syndrome, liver cirrhosis, heart failure, or hormones and drugs. All of these conditions are associated with retention of sodium and water. And of course, the retention of water is more than the retention of sodium. So as the ECF expands and serum sodium concentration drops. If ECF volume is decreased, then I would think that this patient has lost a lot of salt from her body or from his body. And this loss of salt is associated also with loss of water, but the loss of water is not that much as loss of salt. So I have to find where has this salt been lost. Can be lost in the urine, so it gives urinary sodium concentration more than 20 milliequivalent per liter, like patients taking diuretics, patients taking osmotic diuretics, and patients suffering from Addison's disease, and the patient suffering from salt-losing nephropathy. Or the loss of sodium can be through extrarenal sites like in diarrhea, vomiting, ileus, cathartics, and third space loss, or we call it sequestrational loss, in peritonitis, pancreatitis, muscle damage. So here, the patient's ECF volume is depleted while serum sodium is low. The third category is when the ECF volume is normal. Here, the causes might be hypothyroidism or glucocorticoid deficiency. It's not mineralocorticoid because mineralocorticoid deficiency will cause decreased ECF volume. Hypopituitarism and acute pain and psychosis, SIADA, and some drugs. These disorders are associated with pure water retention without change in the amount of sodium in the body. So pure water retention causes hyponatremia. Remember that osmolality equal or natremia equal the amount of sodium in the body divided by the volume of water. Here, the volume of water increased while the amount of sodium is the same. In this condition, the ECF volume wouldn't change much, but hyponatremia will be severe. Syndrome of inappropriate antidiuretic hormone secretion occurs with many CNS disorders, many pulmonary disorders, and some cancers and acquired immune deficiency syndrome. Cancers, especially lung cancer, especially cell, pancreatic cancer, and occasionally duodenal cancer. Pulmonary disorders like pneumonias, viral bacteria, lung abscess, TB, or aspergillosis. And actually, a lot of CNS disorders are associated with SIADA, syndrome of inappropriate antidiuretic hormone secretion. So in SIADA, you will find urea concentration normal or low. Serum uric acid concentration is low because of the excess water. Urine volume is normal or low because here there is absorption of water through the urine, so it can be normal or a bit low. Urine sodium concentration is not decreased because the kidney can excrete normal sodium. And the blood pressure is normal because the ECF volume is normal and the central venous pressure is normal. This is to be differentiated between another condition associated with hyponatremia coming from cerebral disorder. We call it cerebral salt wasting syndrome or cerebral renal salt wasting syndrome. In this condition, there is loss of salt from the body and may be associated or not associated with gain of water or loss of water, but the loss of salt may be more than the loss of water, and the patient anyway can go and drink because of the hypovolemia. And when he drinks water, so his serum sodium concentration will be very low. Here you find urea not decreased because the volume of the ECF is not that much decreased, and the uric acid concentration is again low as what happens in Siada. Urine volume here is high because of the sodium diuresis, and the urine sodium concentration is very high. The blood pressure is maybe low or orthostatic hypotension, and the CVB is low due to some hypovolemia. How would we manage hyponatremia? Actually, we treat hyponatremia as it is. We go and treat the cause, but we treat hyponatremia as it is when there is symptoms and signs of hyponatremia. If no, we go and treat the cause without doing anything for hyponatremia. But when there is signs and symptoms, we go and treat, and we are especially energetic for treatment if there is signs and symptoms of herniation. What is herniation? It is herniation of some part of the brain in any foramina or in any tentorial flexures, like symptom sign like dilatation or dilated fixed pupil, unilaterally dilated pupil, cardiovascular system instability. You find hypotension, hypertension, tachycardia, bradycardia, sometimes hypoventilation, impaired temperature regulation. In this condition, you've got to be energetic in treatment, but how energetic? You have to control your rate of treatment. You don't go and do very energetic treatment or very over enthusiastic treatment, because if you correct more than 10 millimole per liter of serum sodium concentration in the first day and more than 8 millimole per liter on the subsequent days, and if you correct to more than 130 millimole per liter quickly, then the patient can develop a devastating problem called central pontine myelinolysis or osmotic demyelination syndrome, when there is fluctuating consciousness, dysarthria, dysphonia, para and quadriparesis, seizure, coma, and maybe death. And if this condition is advanced, then the patient can suffer a lot and even can be irreversible and can die. It's called osmotic demyelination syndrome because it doesn't affect the bones only, but affects other areas of the brain as well. Here are some hyponatremic patients at risk of neurological complications. The complication can come from either the acute cerebral edema coming from the hyponatremia itself or complication related to rapid correction of the hyponatremia, which is osmotic demyelination syndrome or central pontine myelinosis. And these are the patients that are more vulnerable to brain edema on the right side, and these are the patients that are more vulnerable to develop osmotic demyelination syndrome. Here is the MRI picture of osmotic demyelination syndrome. You can say that there is demyelination of the central cones and other areas of the brain as well. Hypernatremia, on the other hand, also affects the CNS mainly, and the brain is the most vulnerable part of the patient. Here there is plasma osmolality high, and then this causes shrinkage of the brain cells, and this will lead to tearing of the cerebral vessels, some capillary and venous congestion, and eventually there will be subcortical and subarachnoid bleeding and venous sinus thrombosis, and it might be fatal if it's not really corrected. The patient might develop some restlessness, increased irritability, lethargy, muscle twitches, hyperreflexia, tremors, ataxia, and if the osmolality exceeds 375, there will be tonic muscular spasticity, focal and grand mal seizures, and death. So it is very devastating. Actually, hypernatremia is a lot uncommon compared to hyponatremia because the patient can go and drink. So thirsty and drinking can combat the development of hypernatremia in most of the cases, but in the very old, very young, and in patients with loss of consciousness and those who are lost in the desert are uh, predisposed to develop hyponatremia. Then we will have some chat on serum potassium disorders, but I will postpone this to a next part of the lecture. Thank you.